All right, it's 7 o'clock, so I'm going to get started here. So hello and welcome to everybody. My name is Pat Gallagher. I'm the Advancement Director here at the New York, New Jersey Trail Conference. We're very excited to have you all joining us online for a very special presentation from our distinguished guests. For those of you who may be new to the Trail Conference, our organization is a century-old volunteer-powered organization that builds, maintains, and protects over 2,000 miles of public trails and surrounding lands across our region. So we work to ensure that the trails and natural areas we share are sustainable and accessible for everyone to enjoy. And it's with the support of the community and folks like you on the call today that make our work possible. So I'd like to send a big thank you to our volunteers and members and donors joining us today. So our presentation is scheduled for 1 hour today, and before we begin, I'd like to ask that you all remain muted throughout the presentation. We'll hopefully have time for a Q&A at the end, and I'll return to your questions at that time to read to our presenters. So if you do have questions, please be sure to type them in the chat. Please also know that Dr. Mannino will display contact information at the end of his presentation if you're interested in learning more. I'll also add that we will be recording today's presentation and post it on the Trail Conference's YouTube page for you to revisit in the coming days if you'd like. So let's go ahead and introduce our speakers for tonight. Don Weise serves as the Director of the Donor Advising here at the Trail Conference. With decades of experience in conservation and trail advocacy, Don is deeply passionate about promoting the protection and accessibility of our region's trails. He's an avid hiker and trail runner. He regularly leads group hikes and shares his love for the outdoors and fosters a deeper connection to the trails he helps protect. So his work focuses on engaging and guiding supporters in impactful ways, connecting them to the organization's mission to preserve and enhance our trails and natural areas. Our second presenter is Dr. Angelo Mannino. Dr. Mannino is a fellowship-trained orthopedic surgeon with Atlantic Medical Group, specializing in robotic-assisted knee and hip replacements. He utilizes advanced technology to deliver precise patient-specific joint replacements that enhance recovery and patient satisfaction. Dr. Mannino completed his medical degree at Eastern Virginia Medical School with further training at Maimonides Medical Center and Lenox Hill Hospital. He has published widely on hip and knee arthroplasty and is an active member of the American Academy of Hip and Knee Surgeons. Without further ado, I'm happy to hand over the mic to Don Weise.
Thank you, Pat, and good evening, everyone. It's great to have Dr. Mannino here and all of you with us tonight. So we're just going to open up. Dr. Mannino is going to be doing the lion's share of the talking this evening, but I'll be providing an introduction and talking a little bit about some trails that are more forgiving, both wheelchair accessible and not, but ones that can be useful for staying active out there. But first, as Pat said, I want to talk a little bit about the Trail Conference. Those of you who aren't familiar with the organization or have just heard of us, what we do, as Pat mentioned, is we care for an incredible network of 2,200 miles of trails. And it's more than just trails. It's creating the bridges that you cross when you're on your hikes, the steps, the stone steps that get you up the mountain, retaining walls, and things you just wouldn't think about, boardwalks. And the organization does this by working with thousands of volunteers who donate over 80,000 hours of labor each year to keep the trails open. It saves taxpayer dollars and gives us a great network of trails that we would never have otherwise. The organization also works with more than 250 parks, each with their own rules and regulations. So there's a lot going on behind the scenes. And we also preserve land for greenways and long distance trails and protect the land that surrounds the trails as well. We are a member supported organization. So those of you who are involved, thank you so much. We really appreciate all you do. When I first got involved with the Trail Conference some 40 years ago, I was wanting to support the organization, but I didn't know all of the things that go into the trails. Or just how extensive the network was. This is a map that shows kind of the northern New Jersey area with the major long distance trails indicated. We work on both sides of the Hudson River in northern New Jersey and up through the Catskills and beyond. So chances are, if you're in a large state park or even some smaller parks, you probably have been on trail conference trails. Um, so just jump into what it kind of the light that went on in my head when I started to get involved in the organization, and it was that, this is about more than just fun in the woods and walking on trails. Trails and public access to nature are so important, just because they really help us tap into the healing powers of nature, which is a very real and clinically proven thing. I use the trails to unplug from stress and technology. It's a great way to learn about plants and animals. Great way to engage in volunteer service. We have a lot of volunteers and to bond with nature and with each other. But perhaps most important of all is, it's a way for us and our children and grandchildren to discover our connection with Earth and the role that we play in protecting it. So a lot more than meets the eye. In addition, there are great mental and physical benefits to hiking. Certainly stress and anxiety reduction, connecting with people in nature, creative problem solving is huge. I use that all the time. And then just the physical health benefits, burning fat, building strength, multiple muscle groups, preventing heart disease, and regulating blood sugar and blood pressure. So I'm a big fan of getting outdoors for my workouts, and I hope you are too. So we're going to jump in. I've got two different states and two different categories of trails that we're going to cover here. So we're going to start with the most wheelchair accessible trails in northern New Jersey. We're going to start with the Saddle River County Park Bike Path. This one is located right in the heart of Bergen County, running from Ridgewood to Rochelle Park. It's about a little less than 8 miles, and it's fully paved. The only caveat with this, if you're out on it walking, keep an eye out for bikes, especially on weekends. A similar trail, but shorter, if you live in the Morristown, Morris County area, there's a great traction line recreation trail. It's a little less than 3 miles, and it's got some fitness stations as well, so you can do cardio and strength work at the same time as you're walking. Those of you down by the Delaware River and further south, there's the DNR Canal, Delaware and Raritan Canal State Park Trail. This is not wheelchair accessible in all areas, but it's a beautiful place to get your exercise. And then those of you who are by the Jersey Shore, the northern Jersey Shore, is the Henry Hudson Trail, which is more than 28 miles long. It's paved, and it's very scenic. I haven't spent a lot of time on this, but it's a wonderful trail. Now I'm going to move into northern New Jersey's less wheelchair accessible trails, but still great places to check out. And I'm going to recommend that if you want to check these out, do take a picture of the screens, because they've got information to connect you with how to find them. One of my favorites in my backyard is Long Pond Ironworks State Park. So it's about a 1 mile loop that you can do, a lollipop loop on a gravel and grass dirt trail, but it's got fantastic remnants of the ironworking days, including buildings and furnaces and water wheels and so forth. So I urge you to check that out. You can explore much farther than that, and the Highlands Trail runs through it. Two other trails in Sussex County are the Sussex Branch and Paulinskill Valley Rail Trails. And they kind of form a crisscross top half of a triangle with the two trails. You'll see that on the map in a second. But these are fantastic if you don't need a paved trail and you want a beautiful wilderness experience. In addition, I'll show you in a second, but you can connect those two trails to complete a loop we call it the half marathon loop. It's about 13 miles or so. And then out in Morris County and Columbia and Hunterdon County is the Columbia Trail, a little over 16 miles, following the south branch of the Raritan River. And it runs from Bartley in Morris County out to High Bridge. Super beautiful trail. And then for you more urban folks, in Essex County is the 36-mile Lenape Trail, which is really a mix. It's not a rail trail, but it's a mix of city streets and small parks, a lot of diverse scenery, and it's a great way to get an escape without driving too far if you live close to the city. So just taking a look, if you look in the top left, the crisscross trails, the yellow and the orange, are the Sussex Branch in yellow, the Paulins Kill in orange, and I've drawn a little dashed line that shows the connector trail for the half marathon loop. And then, green, Columbia Trail, blue, Delaware and Raritan Canal. Green is the Henry Hudson. You can see blue is Essex County's Lenape Trail, and pink purple is the Saddle River bike path. To the north, you can see Long Pond Ironworks in white and parts of the Long Path in yellow in the top right of the screen. Um, Jumping over to New York, there are bikeable and wheelchair-friendly trails for sure to find in New York. And one of my favorites is the Bear Mountain All Persons Trail. It's about a 1 mile walk, and you drive up to the top of Bear Mountain, and you can literally take a wheelchair on a 1 mile hike with just drop dead gorgeous views of the Hudson River, West Point, and other places. Similar scenery, but down by the water is the Ashokan Rail Trail. That's in the Central Catskills. And then the Empire State Trail, which runs from New York City all the way to the top of New York and all the way west to Buffalo. That's a very bikeable trail. And then the Heritage Trail for you Orange County folks runs from Monroe, New York to Middletown and is being extended from there. And that is a paved trail for the most part, which is really beautiful. I'm going to go over to some easier walks, not necessarily wheelchair accessible, and we'll talk about those a second. Up in the far northern Catskills, this is Greene County, New York, you'll find the Catterskill Rail Trail, some pronounce it Caterskill. It's about 1.5 miles. It's actually longer than that now. It's extending from Tannersville through Haynes Falls and to North-South Lake. So, I mean, just being there is gorgeous. The Croton Gorge and Briarcliff Peekskill trails are on the east side of the Hudson, and those are mostly bikeable trails. And then just talking about the Empire State Trail, it intersects with a trail called the Wallkill Valley Rail Trail, and this is in Ulster County. So if you're thinking Gardner, New York, New Paltz, New York, to Kingston, that's a really beautiful trail, but you'll want to have a gravel bike for that or a hybrid type bike. And then purely a walking trail, but beautiful. Close to the state line is the Sterling Forest Lake Loop. It's 4-ish miles, 4.5 miles around, and it does have some short, primitive single track sections, but generally is an easy route to follow. So these are some of the maps. This is the lower Hudson Valley, New York. And if you look on the right, you can see the Hudson River going north to south, right adjacent to the yellow trail that you see. So that's everything on the right. The yellow trail and the orange trail are the east of Hudson trails. You're looking at the Briarcliff Peekskill Trail and the Old Croton Aqueduct in yellow. And then that long line heading up toward the top left corner is the Heritage Trail, and that's in Orange County, New York. And then just one more slide going up the Hudson. You can see in yellow is that Wallkill Valley Rail Trail I was telling you about with the where you need the gravel bike that connects and is co-aligned with the Empire State Trail, which is in green. And then the beautiful Ashokan Reservoir Trail is in red. You can see it riding right along the north end of the Ashokan Reservoir. And then way up north by Tannersville, you can see the Caterskill Rail Trail in blue. So be happy to answer any questions on that later, but for now, I'm going to hand over to Dr. Mannino.
Just give me 1 second. I'm going to try to share my screen. Everybody can see that? All right. First, I want to thank Don and Pat for giving me the opportunity to talk, and I want to thank all of you for taking time out of your Wednesday night to come and join us for this talk. My name is Dr. Angelo Mannino. I'm an orthopedic surgeon. I specialize in hip and knee replacements. And basically, my job is to talk to you about how you can get back to hiking and dealing with arthritis, both in the hip and in the knee. So just to start off with some, basic definitions, just so we're all on the same page. When it comes to the knee, we're talking about three bones that come together to form a joint. Talking about the femur or the thigh bone, the tibia or the leg bone, and the patella or the kneecap. And the knee joint is made up of where those things come together so that they can move, so that your leg can bend and straighten, to get you to be able to walk up and down stairs and go on hikes. When it comes to the hip, we're talking about basically two major bones, the pelvis and the femur. So the pelvis is the big ring that makes up your hip socket, and it also connects your spine to the rest of your body. And that's where you have the socket or the acetabulum. And then at the top part of the femur is the femoral head, and that's the ball that goes into the socket or the acetabulum. And that's what makes up your hip joint. So it acts as like a ball and a socket, very similar to the shoulder. And lastly, the last term I wanted to define was cartilage. So what is cartilage? Cartilage is a smooth surface that's on the end of the bones that allows for what we call frictionless motion. And so the goal is so that when you walk or when the bones are moving, there's not any friction between them so that everything glides smoothly, right? And the knee is actually known for having the thickest cartilage in the body. And then in the knee, addition to the cartilage, we also have the meniscus. So the meniscus is like a cushion that acts as like a shock absorber to once again make things like walking on uneven ground or anything that we do with impact reduce the amount of stress that goes across the bones. So now we have to define what's arthritis. So arthritis is when that cartilage wears away. And so what happens is over time, for a number of different reasons that we'll get into later, that cartilage has worn away. And so what you get is areas where, like you can see in the picture towards the right, when the cartilage is gone, you see the underlying bone. And then what happens is that bone rubs on the bone of the joint, of the other bone that makes up that joint, and you get pain, you get swelling, you get inflammation, and things like stiffness. So what are the risk factors for osteoarthritis? The biggest one is age. As we get older, that cartilage tends to wear away. Family history, there's a little bit of a genetic component to it. Weight plays a big part of it. About 4 to 6 times your body weight actually goes through your knee when you're doing things in a bent position. So things like going up and down the stairs, climbing up on things, anything with your knee in a bent position actually puts about 4 to 6 times your body weight through your kneecap. And unfortunately, arthritis is a chronic condition that we don't really have any therapies to slow the progression of, but we do have treatments to help relieve your pain and improve your range of motion. So again, like we mentioned before, arthritis is when you have a degenerative disease of that joint and the cartilage starts to wear away. It's our most common cartilage disorder that we see in orthopedics. They estimate about 67 million Americans will be diagnosed with osteoarthritis by the year 2030. Within arthritis, there are several different types. The most common is osteoarthritis, is what we call normal wear and tear as we get older. There are some immune type arthritis. There's rheumatoid, psoriatic, Lyme disease. Basically, these are arthritis where your body produces too much inflammation, and that leads to the destruction of the cartilage, compared to, like I said, the osteoarthritis where it's just normal wear and tear as we get older. Gout is a crystalline disorder where your body will deposit crystals into the joint. And again, that can cause wearing away of the cartilage. And then there's another type that's a category all of its own, which is post-traumatic arthritis. So that's typically seen in patients who have maybe had like a fracture or a break in their bone, or they've had some kind of previous surgery before, like they've had a meniscus tear and they've had meniscus surgery before. And so they're now predisposed to getting arthritis in that joint. And again, the common symptoms between all of them is going to be the pain, the stiffness, the swelling, and decreased range of motion. So what are the symptoms that patients commonly present with? When it comes to the hip, it's mostly pain around the hip, sometimes in the lower back, most commonly in the groin, can sometimes radiate into the buttock or into the knee. Pain that flares up with different activities, depending on what you're doing. So a lot of patients will complain of stiffness in the morning, especially they got to get up and start moving to really get that hip going. Sometimes locking or sticking, like I said, or stiffness of that joint. Sometimes patients can feel a grinding sensation, or they can actually hear crackling as they walk or as they move that hip. And then over time, again, you're going to start to lose that range of motion, which is really going to impair your ability to walk and do the things that you want to do. And again, for whatever reason, patients can always tell me when the weather is going to change, because they're always complaining and saying they feel it in their hips or they feel it in their knees. And again, when we look at knee arthritis, pretty similar: pain with activity, loss of range of motion, stiffness, swelling, tenderness. Sometimes you feel like the knee is going to give out or buckle. And over time, when the arthritis progresses to severe enough, you can actually start to see a deformity of that joint. Some patients will notice that they're a little bit more bow-legged or a little bit more knock-kneed as that arthritis starts to progress. So who's affected by arthritis? Like we said, when it comes to osteoarthritis, it's most common in patients who are getting older because that's what the disease is from. As we get older, that cartilage just starts to wear away. Like we said, it could be injury or trauma. Pretty uncommonly, you can have an infection in that joint. Again, there is a genetic component to it. And lastly, like I said, the weight can play a role in it because, like I said, about 4 to 6 times your body weight goes through that knee joint and through your hip joint um, when you're doing things that require you to go up and down the stairs. It does affect women more common than men. We don't really know why. It just seems to be the case. And again, patients who are more prone to chronic medical conditions like diabetes, heart disease, and obesity are more likely to develop arthritis. So this is probably the most important slide when it comes to how we're going to treat and how we're going to deal with the arthritis. And, for the people on the call, this is the things that you want to know and what we can do for you to help alleviate your pain, to help get you back to doing the things that you want to do to get back onto these trails. And they range from the least invasive on the left to the most invasive on the right. So when we talk about the least invasive, we talk about the non-pharmacological things, exercise and stretching, physical therapy, weight loss. Again, every pound you lose feels like 5 pounds less to your knees and to your hips. Acupuncture, chiropractic, heat and cold. And then in the middle, we have the next level of treatment, and that's the pharmacological things. And that's medications and injections. And the medications, we have basically two major classes. Tylenol, which is a pain reducer, and then we have NSAIDs or non-steroidal anti-inflammatory drugs. Those are things like Aleve, Motrin, Advil, ibuprofen. Their role is to help reduce inflammation in the body. And if you remember from earlier, osteoarthritis is an inflammatory process. Your body doesn't like when the cartilage wears away. It doesn't like when the bones rub together. And so it produces all these inflammatory cells that cause pain and swelling. And so the anti-inflammatory medication's goal is to help reduce that. The next thing is topical creams like a Voltaren gel you may have heard of. That is basically ibuprofen crushed into a gel that you can rub directly over the joint. And some patients swear by it. And I'll be honest, I'm one of those patients. I love Voltaren gel, elbow pain, knee pain, whatever it is, always seems to work. The next step above that is things like pain medications. And those are typically stronger pain medications like tramadol or opioids, things that we tend to reserve for after surgery, or if for whatever reason you may not be a surgical candidate, those are things that we would refer you to the pain management doctors for. And then next is joint injections. And then the joint injections basically come in three types. The steroid injections. So the steroid is, again, an anti-inflammatory medication. We inject it directly into the affected joint, whether it's the hip or the knee. And its goal, again, is to reduce the inflammation in that joint to help alleviate your pain and symptoms. The next one is the gel injections. There's a lot of different brands of the gel injections. They're essentially all the same when it comes to outcomes and effectiveness. But basically the goal of the gel, and I have a slide on it next, its goal is to lubricate the knee joint. A lot of patients, and it's very misleading because when you watch the commercials, they think you inject the gel and it almost acts as like insulation, like foam insulation that you spray, and suddenly you have more space in the joint. And unfortunately, that's just not the reality. The gels help to lubricate the joint. It's hyaluronic acid, a naturally occurring substance in the body, and its goal is to help the bones glide more smoothly to help alleviate that pain. Because if you remember, the reason that we're having the pain is because the arthritis has worn away the cartilage and you're starting to get the bones rubbing on the bone. And so the goal of the gels is to help lubricate those joints so that you get rid of pain. PRP, or platelet-rich plasma, is a special type of injection. Basically, what we do is we actually draw blood from you. We spin it in a centrifuge, and then we take the special proteins that are spun from that blood and then inject that into the joint. Basically, it's a bunch of stem cells. And again, the goal is to help reduce the inflammation. The only downside of PRP is a lot of practices. It's cash-based, so you kind of have to pay out of pocket for it. When it comes to supplements, things like glucosamine, turmeric, CBD oil, things you can get over the counter, I'm a big believer of take what you think is going to help you feel better. So if you're taking turmeric and you say it feels great, perfect, keep doing it. I'm all for it. And then lastly is the surgical part, and this is kind of where I come in, and that's joint replacement. So I'll touch a little bit about on that next. But like I said, this is the slide that I wanted to focus on a little bit too, because the gel injections, like you can see in this picture, they make it seem like the gel is going to fill the knee joint and suddenly increase the space between the bones. And unfortunately, that's just not the reality. And for the gel injections, there's two different types. Basically, you can do it in a series of 3 shots, 1 week apart, or you can do them all in one shot. And again, there's really no difference between the two. It's mostly just patient preference. And I'll be honest, a lot of it is insurance based. We have to submit to the insurance companies for approval for them, and then depending on which one's on the insurance company's formulary is kind of how we deal with it. But again, most of the time I tell patients the gel shots, if they do the series of 3, usually at 2 weeks after the third shot, because they tend to build on each other. By the time they've gotten the third shot and the 2 weeks later, they're usually feeling better. And if they're effective, we can repeat them every 6 months. And again, that goes back to the insurance company. And that's where we get that timeline from, is because the insurance companies will only approve it for every 6 months. Again, like I said before, although a lot of patients will report relief of their symptoms with the viscosupplementation, that's just the fancy words for the gels, nothing's been ever shown to reverse the arthritic changes or slow the progression of the arthritis or regrow that cartilage. And that's why I just want to be very clear about how the gel works, because a lot of these commercials or advertisements that you'll see will be like, they inject the gel, suddenly the joint fills up with this material, and now there's no more bones rubbing on the bone. And unfortunately, that's just not the case. So first we'll talk about the knee. So what is a knee replacement? The goal of the knee replacement is to replace that worn out cartilage that has been degraded by the arthritis. And so it's an artificial joint using a combination of metal and plastics. And sometimes we use bone cement to hold that hardware in place. And a lot of patients think, well, you're just going to go in there and chop my bone off. And really, that's not the reality of it. Basically, what we do is, if you can see it in this picture, we kind of resurface the bone at the end and kind of shape it to look like this. And then the implant sits on top of that. So we shape the end of the thigh bone or the femur, we shape the top of the shin bone or the tibia, and then we actually, depending on how bad the arthritis is underneath the kneecap, we'll do the same thing. And with a little plastic button, we'll go underneath the kneecap as well. So these are the typical x-rays that I would see in the office. Obviously, on the left, you see is a more normal knee. You can see how there's space between the two bones, right? Here's your femur, your thigh bone, tibia, or the shin bone. And you can see there's space between the two. And when you look at the picture on the right, that space is now gone. You can see that this patient is completely bone on bone. They've got all these bone growths or osteophytes. You can actually see that the bone has gotten a little bit whiter or sclerotic. That just means that there's more force actually going through the bone. And so the bone's actually hardening in response to that. And so again, this is what a knee replacement looks like. We take that worn out cartilage, we resculpt the end of the bone, we replace it with metal and plastic, and you can see on the x-ray how this patient that was completely bone on bone now has a new artificial knee. So this is the x-ray shows the metal, so this white is all the metal of the implant, and in between, you can't see it, is the plastic or the polyethylene that acts as your new joint. So now the hip, pretty similar. You can see on the picture on the left, this is what an arthritic hip would look like on an x-ray. You can see that, here's the socket right here. This is the femoral head or the ball that goes into the socket. And you can see the space is completely worn away. You've got all these osteophytes or bone growths that are occurring. Again, that sclerosis or that hardening of the bone, because the joint is now seeing more force going through it than it did before. And so the way to alleviate that pain and give you back your range of motion is with a hip replacement. And so it comes in several different components. The first one is the acetabular shell. So basically what we do is, where your socket used to be, we put this metal shell. Inside that metal shell goes a plastic or polyethylene liner. Where your femoral head used to be, you can see this here. We actually remove that. We put a stem inside the bone with a new femoral head inside, femoral head on top, excuse me, and then that goes into the plastic liner, and that becomes your new hip joint. Similar to the knee, those can either be cemented in place or what we call press fit or wedged into place, where you don't actually need any cement to hold it in. So again, this is what one would look like on an x-ray. So you can see on the image on the left, this is before the surgery. You can see the joint space is kind of worn out. They've got all these osteophytes here. You actually get sometimes you'll see cysts inside the bone. That just means that the bone is kind of worn away underneath where the cartilage was. And then this is what a total hip replacement looks like. So you can see here's the new acetabulum or the shell. Here's the stem inside the bone. We've removed the old femoral head, and they've gotten a new one, either made of ceramic or metal. And between the two that you can't see on the x-ray is the plastic liner. So how do you know if you have hip or knee arthritis? Most commonly, patients over 50, people who used to be a lot more active, but now they're saying they're not doing those normal activities because of how much pain that they're having. Pain with those activities where they're required to take frequent breaks, or they can't go for as long as they used to. They may say, oh, I used to be able to walk 10 miles, now I can only walk 3, and I have to stop more frequently. Sometimes patients will complain of pain at night or even at rest. Like I alluded to earlier, they'll have stiffness or decreased range of motion because of that joint space that's worn away, and you've had all that new formation of bone or osteophytes. They'll feel like that cracking, grinding sensation. Specific for the hips, a lot of patients will say they'll have trouble putting on their shoes or on their socks because they just can't bring their foot up into that figure four position to get their shoes and socks on. And most commonly, they'll complain of groin pain. Um, so, are you a candidate for a hip or knee replacement? So the answer is most patients is yes. We don't really look at age, believe it or not. Age is just a number. Oldest one I've ever done, I think, was 96, who had a hip replacement. So it really just depends on the patient, and it's always a case by case basis. So when it comes to hip or knee arthritis, the patients that are coming in and asking for a hip or a knee replacement are the ones who are having so much pain that they can't do the things that they want to do. They've now had to change their lifestyle or alter their lifestyle completely because of the pain that they're having, and they're just generally unhappy with the way that they've had to change their lifestyle for that pain. And on the flip side of that, they've also had to try at least some of the conservative treatments, whether that's weight loss or activity modification, physical therapy, the anti-inflammatories or the pain medications, the injections, or sometimes even a walker and cane and things like that. But I think the biggest thing to remember is that this is an elective surgery. And I always tell patients when they come into my office, I'm not trying to sell you the car. I'm here when you're ready to buy the car. And I'll tell them I'm not going to tell you when you need the hip replacement or the knee replacement, you're going to tell me. It's when you're finding that the knee or the hip is becoming a functional disability. It's impacting the quality of your life, that you can't do the things that you want to do anymore. That's when we talk about surgery. So again, it's not an emergent surgery. It's a quality of life surgery. It's when all the other things have not worked. You find that you can't live with this anymore. And like I said, it's a big, bold, and in red. Only you can decide when you're ready. And I'm here when you're ready. My job is to tell you if you're a good candidate for it. A lot of times I'll get asked, what's the recovery like? Usually I tell patients they'll stay in the hospital usually 1 or 2 nights. Sometimes they'll even go home the same day. Usually I tell them full recovery is anywhere from about 2 to 3 months. Most patients working hard with the therapist by about 4 to 6 weeks are pretty independent and doing everything that they want to do. Usually for the first 1 or 2 weeks, it's nice to have somebody there to help you out. But again, you don't want somebody who's gonna sit and wait on you hand and foot, because the point is that you were able to do most of the things that you wanted to do with this hip and knee arthritis. And my goal is to alleviate your pain so that you can do those things. So the thing I tell patients is, after a knee or after a hip replacement, don't just sit on the couch and do nothing. Your goal is to get up and walk. And I tell them, my part of the procedure is easy. The surgery is easy. The recovery is the hard part. And that's the part that you got to do. And so I make that very clear beforehand that they're going to have to work with physical therapy 2 to 3 times a week, at least for 2 or 3 months, so that they're getting the most out of their knee or out of their hip. And another thing I tell them is, the old adage of you don't use it, you lose it is true, because you'll see these patients who, they have their knee or the hip replaced and they don't walk and they don't do anything, and the knees actually get very stiff. And then the whole reason that we did the surgery, which was to help alleviate your pain and your stiffness, has now come back. And so that's something I always want to make clear to them, is that the recovery is probably more important than the surgery itself. Usually, immediately after surgery, you're started with a walker for first couple of weeks. Eventually, you graduate to a cane. And then the goal is to get you back to walking with whatever you used to walk with before. For some patients, that's a cane. For some patients, that's nothing. And that's my goal. And my goal is to get you back to your level of activity that you were doing before the surgery. The other thing is, again, managing expectations. Usually I tell patients no driving for about 3 to 4 weeks. And typically that depends on which side they're having done, and actually what kind of car they drive as well, if it's an automatic or a manual car, if they need both feet to drive or not. Usually, like I said, back to work, I tell patients ask for 3 months off. And if they go back sooner, great. It's usually easier to ask for more time in the beginning than to try to ask for more time if you need it. And again, most of the time, by about 4 to 6 months, you forgot you even had the surgery. In terms of the outcomes of hip and knee replacements, they've gotten really, really good at manufacturing these things. About 90% of these are lasting at least 10 to 15 years, and over 85% are lasting 20 to 25 years. So those done well without complications. Usually it's just one and done. And again, the biggest thing is your quality of life. My goal is to get you back to your activity that you had before surgery. So whether that's walking, biking, hiking, playing with the grandkids, pickleball, tennis, skydiving, doesn't matter what it is. Our goal is to get you back to that. Um, and then lastly, I wanted to wrap up with this because again, this is the whole reason why we're here is what to do with arthritis, and how to get back to hiking. So these are just some tips and tricks that I've come up with. And I'm sure there's more, but so just some things that I felt were important that we can talk about. So the first thing is walking every day. Walking on flat ground is great. It's the least impact on your knees and on your hips. The best thing actually to help keep your range of motion and to keep you active is actually what we call the recumbent bike. So it's a bike where you sit and you just pedal. That actually allows you to fully extend and fully bend your knee. So it gives you great range of motion of the hip and of the knee, and it's the least impact on your body. Then, like I said, it's walking on flat ground. And then you have things like the treadmill or jogging on regular ground. Those are the most impact on your joints. Conditioning yourself, right? Don't just jump into a 25-mile hike when you haven't done anything in 3 or 4 months. Listen to your body, trust what your body's telling you to do. Gradually increase, what you do. Start easy, get a little bit, get yourself, resituated, and then slowly build your tolerance back up. Always make sure you're stretching. Last thing you want to do is pull a muscle while you're hiking or while you're out there, and it makes it difficult for you to get back. Always drink a lot of water. This can't be said enough for anything in life. Hydration is important for your muscles. Um, a lot of things that something that nobody would really think about, but again, eyesight plays a major role. Having good eyesight, whether you need glasses or you don't, making sure that you can see the ground that you're walking on. Is it flat? Is there a hole? Is there anything that can get you into trouble? So making sure that you can see the path ahead of you. Again, pacing yourself. This goes back to listening to your body. Some days you're going to feel better than others. So just make sure that you pace yourself as you're doing these hikes. You know, it's not a competition, or maybe it might be, but most of the time we're doing this recreationally. So just listen to your body. If you need to take breaks, take breaks. And then again, modifying your gear. So if that means using walking sticks, carrying a lighter backpack, um, just again, listening to your body, not pushing yourself more than you need to so that you can enjoy the activity like Don was talking about earlier. This is my contact information. So if anybody's interested in learning more or has any questions that I'm not able to answer in the chat, I have two offices, one in Paramus, one in Wayne. Happy to see you at either of them and answer any questions. And I think Pat's going to go through the chat and see if there's any questions, and I'm happy to answer them.
Okay, thank you, Dr. Mannino. So we have a few questions, and yeah, if anyone on the call has any questions, please add them to the chat. Read them out. So we had a question about your thoughts on therapeutic massage for pain relief and its effectiveness.
So I'm not entirely familiar with it, but I can't see how it would hurt. Again, I'm a big believer in doing whatever you think is going to help your body feel better. So whether that's going to the chiropractor, acupuncture, massage, um, if it's going to feel better, I'm happy to endorse it. Like I said, there's nothing that's going to reverse the progression of arthritis. There's nothing that's going to cure the arthritis. Um, but if it's helping to alleviate your pain and it's helping you getting back to your activities, I'm all for it.
Right. And another question about how you feel about or your thoughts on regenerative therapy and stem therapy.
Yeah, so that's pretty similar to the PRP. There is some literature out there to support it, especially for patients with knee arthritis. Like I said, basically it's taking your own body stem cells, and injecting them into the knee. The thought was maybe that you'd be able to regrow your cartilage back, and unfortunately, that's just not the case. Basically, they kind of work similar to the steroid injections. Their goal is to just reduce the overall inflammation in the body. And again, if it helps alleviate your pain, I'm all for it. The only downside with those is they are usually cash based, and you do have to pay out of pocket. There's not many insurance companies that I'm aware of that cover it. And so the cost kind of varies depending on which joint you're injecting. Usually for a knee or a hip, can range anywhere from $1,000 to $2,000. So again, it kind of just depends. I've seen it mostly in the patients who are like, I really don't want surgery. And so they're willing to do whatever it takes to avoid surgery or postpone or delay surgery. So they're willing to pay for it. But again, if it helps, I'm all for it. It's just with those, the cost is it's pretty costly.
Right. And we had a question about orthotics in your shoes and if they help alleviate knee or hip pain.
So there is a pretty intimate relationship between your foot and your knee and your hip. Um, the best people to talk to with that, it really all depends on what kind of foot issue you're dealing with. So for some patients, it's they're flat-footed, so they use an orthotic that gives them an arch, which helps alleviate some of the pain. The best thing to do actually for that would be to see a foot and ankle doctor first. What they'll do is they can take x-rays of your foot, they can evaluate your foot and determine if there's any orthotics that you would need prior to anything else. And sometimes you'd be surprised, that will help alleviate the knee and the hip pain because it's now redirecting your foot into a more anatomic position, which is helping to alleviate the amount of force that's going through your knee or through your hip. And so usually we'll send them, if I have a patient who's, let's say, flat-footed, or they've had some kind of ankle surgery, or they have ankle arthritis, I'll refer them to a foot and ankle doctor first. And basically, we work our way from the ground up, get their foot realigned, because the knee, if you have to do surgery on the knee or on the hip, especially though for the knee, because it's that bone is associated with the ankle, right? The tibia makes up your knee joint at the top and then your ankle joint at the bottom. So if your ankle joint or your base is not where it's supposed to be, then doing the knee replacement may not be great because now it's going to redistribute forces through the knee in a way that's not normal. And it can actually lead to the implants failing sooner than they're supposed to. And so usually if patients have some kind of foot or ankle issue, I'll refer them to a foot and ankle doctor first, determine if there's anything that needs to be done there, and then kind of work our way back up to the knee.
Excellent. Okay. Next question, I think we'll probably go to Don. Do you have any recommended hiking aids, boot brands, or pole brands?
Oh yeah,
Sure.
I would definitely defer to Don for that one.
So I'll start with poles, and really poles. Any kind of pole will work for you until it doesn't. So the question with buying poles is, what's the longevity going to be for you more than anything? And I personally like Lecky and Black Diamond brands, but really any pole will work for you. You just, it's best to try it out. I would definitely recommend going to an outdoor outfitter, REI, Ramsey Outdoor, one of those, to try them out and get some advice from people on what they like as well. Um, as far as boots go, really boots are highly individual. Again, while you're checking out your poles, I recommend going to that outfitter and trying them on, walking around in them and so forth. And then, personally as a trail runner, hiker, I love hiking. I do almost all my hiking in Hoka Speed Goat trail runners. They're super cushiony, super stable. You couldn't, it's hard to believe that they're not high tops, but they really keep you from twisting an ankle and protect you very well. So those are the main aids, that I would use. I also occasionally I have some knee issues and I'll use a knee brace, but that's more Dr. Menino's area of expertise.
Don, there was a question about the trails that you were mentioning. Are any of them strenuous or easy?
Okay. Yeah. So The the only trail that I mentioned that really has any significant uphill or downhill is the Sterling Lake Loop in Sterling Forest. That's the one that's just about 4.2 miles. It's largely easy, but it has a bit of up and down on the north end of it. The rest of them are really pretty flat and pretty smooth, uh, as long as you're on foot. Um, it's just a question of how far you want to go. Some of them are very long trails, so you can hike as far as you want.
Right. Right. We've reached, I think that's all the questions that have been written in the chat. Is there any other questions out there?
Oh, here
Poles
comes
help the
one.
knees, Don. You see it, yeah. Or Dr. Menino, I don't know if you know this, but do hiking poles, would that help the knees?
To be honest, I'm not entirely sure. Um, I imagine that they would, because again, anything that you're going to use your arms for is going to help alleviate, the amount of force that's going through the knees. So basically, you're kind of just redistributing the force rather than going straight through the legs. You're also using the arms. So I imagine that they do, but that's a great question. I'd be happy to look that up, but I'm not entirely sure what the biomechanical uh situation is with that. So I'm not, I'll just answer you honestly. I don't know.
I mean, anecdotally, I have knee pain, and poles really do help. They do. And also, they give you a better workout. You burn 15, percent more calories and get your upper body in the game as well. So, multiple benefits.
And he mentions that the poles help her with depth perception as well. And kind of along those lines, what are your thoughts on knee braces? If I guess if they're useful, helpful, preventative. Uh,
Yeah, so the knee braces, because there's so many, usually my thought is if there's a lot of companies that make the same thing, that means they're all either equally good or equally bad. And unfortunately, that tends to be the truth of it. So the knee braces and the knee sleeves. So knee sleeves are like those neoprene sleeves that you can buy at the pharmacy. They're basically just like super tight around the knee. They give you a little bit of extra stability and comfort, and support. They're again, nothing is curing the arthritis. Nothing's getting rid of that, but sometimes they'll help reduce swelling because of how tight they are around the knee. So that'll help reduce inflammation. That'll help reduce the pain. And then knee braces. So when I talk about sleeves versus braces, the sleeves are the ones, like I said, that you buy over the counter. The braces are the ones that we would prescribe you in the office. Usually they have like metal bars on the side, little hinges. There are some braces that are made, we call them offloader braces, where they're basically pushing the knee opposite in the direction of that you have the arthritis to try to alleviate some of the joint forces that are going through the knee. Those have been shown to give you some relief, but again, these are all temporary fixes. They're all um, nothing again is curative. These are all just things to help alleviate your symptoms. So again, I go back to if the braces and the sleeves that you feel are helping you and you're able to do the things that you want to do, again, I'm all for it. I'm always happy to say, if you want to try the brace, give it a shot. And if it's not working, we'll come back and talk again, but at least we can say we tried.
so Pam is asking, what if you have a knee replacement, what level of hikes can you return to?
Whatever level you were at before. The goal of these surgeries is to get you back to the level of activity that you were doing before. Um, the most extreme example that I've seen in my career, when I was a fellow, we had one patient who he literally would do skydiving. And he went back to skydiving, I think like 2 or 3 weeks after his knee replacement. Then unfortunately he fell during skydiving and ended up breaking around the implant, had a revision surgery, and then went back to skydiving. So the goal is to get you back to that level of activity. So if you were doing these 20-mile hikes, my goal is to get you back to doing 20-mile hikes. Well, are you going to do 20-mile hikes 2 weeks later? I don't know, but that's the goal, is ultimately to get you back to what level of activity you're at. And a lot of these surgeries, especially the knee, there's no restrictions. There's no things that you're not allowed to do unless there's some kind of mechanical issue, or for whatever reason you're having some kind of revision surgery. Then that's, again, these are case by case basis. But overall, the goal is to get you back to the level of activity that you were at before. So if you were hiking those 20 miles, we want you back hiking those 20 miles. We want you to live your life.
Great. All right, I think that is all the questions we've had. So we got a new one. Oh, yay, from Pam.
Thanks, Pam.
Yeah. So yeah, so thank you, Dr. Menino, and thank you,
My
Don.
pleasure. Thanks for having me.
Oh, we got one more question actually. So how to maintain bone strength when aging to avoid breaks, like i.e. calcium supplements. Is
Yeah,
there a
so
way to avoid?
this is a complicated question, because there's some literature that says taking vitamin D and calcium does help reduce to try to maintain bone strength. Excuse me. There are also medications that you can take, that I would say, if you wanted to talk to your primary care doctor about, that they can recommend for you. Those can help reduce osteoporosis. Um, Unfortunately, this is just a consequence of all of us getting older, is that the bone does get more brittle, it does get weaker. But I always recommend, especially after, I see a lot of patients who also have hip fractures, things like that. I'll always recommend vitamin D, calcium. The vitamin D, you're out in the sun, fantastic. But you can also supplement it. Same thing with the calcium, because the bones, you need the vitamin D to absorb the calcium, and the calcium is what your bones are made of. And then there are, like I said, certain medications and injectables that you can discuss with your primary care doctor to help reduce the progression of osteoporosis. Again, it's one of those things where nothing is going to stop it, but we can try to slow it down.
Great. And just a reminder, we've recorded this presentation and we'll be posting it on the Trail Conference's YouTube page in the next few days. So if you want to revisit this presentation, you'll find it there. You have Dr. Menino's contact information here, so please take note of that if you'd like to reach out. And please always reach out to us at the Trail Conference if you have any questions about trails, hikes, anything to do with the outdoors in our region. We'd love to talk. Thank you so much. Have a great night.
Thank you, everybody.
Thanks,
Sure.
everyone. Have a great evening.